We're moving on to the maternal adaptations to pregnancy. And if you follow your outline again, you'll notice that the next few objectives deal with this part of the content. We're going to discuss the maternal physiologic adaptation to pregnancy. We'll differentiate among presumptive, probable, and positive signs of pregnancy. And we'll discuss all of the psychosocial and behavioral changes. And this is where we really incorporate the family into our concept of maternity care. Physiological changes in pregnancy occur in every system in the body. It is a time of profound change for mom. Initially, we have the influence of, ovarian hormones and pituitary hormones. And these hormones sort of help to maintain the pregnancy. They decrease the contractility of the uterus to keep it from expelling the product of conception. They help with implantation, provide some nutrition. They maintain the endometrium. The pituitary in particular secretes LH, luteinizing hormone, and that helps maintain the pregnancy. Later, we see, HCG is secreted, and that also helps to maintain the pregnancy until mom starts secreting her own estrogen and progesterone, which are responsible for nearly all of the really profound effects on most of the systems. Okay, so obviously, hold on, let me get rid of some of this stuff. Obviously, the reproductive system undergoes a lot of changes. So we can start with the uterus. That's where everything's happening. Estrogen makes it grow. And progesterone keeps it quiet. It also helps it grow a little bit. But that sort of keeps the body from expelling, and it allows the uterus to enlarge and stretch. And if you think about the size increase, if you looked at a non-pregnant uterus, it's really like about the size of your fist. And if some of you have the chance to go into a C-section, you'll see the size of the uterus at term. Although it starts to contract pretty rapidly, it goes from 70 to 1,100 grams, which might not mean anything to you. But if you think about how big it has to stretch to fit around an 8-pound baby, let's say, with the placenta and the amniotic fluid, that's a pretty big change. And then it has to contract pretty rapidly and go back to its normal size. The cervix and all of the soft tissue in the vaginal area also undergo a lot of changes. And that's where we get some of our probable signs of pregnancy. We get our Chadwick sign. Chadwick's sign is that bluish coloration of the vaginal mucosa and the cervix. We get Goodell's sign, which is a softening of everything. Softening of the cervix. You can get Hager's sign. These are all probable signs of pregnancy, and I will go over them again, I promise. Hager's sign is when you can flex the lower portion of the uterus, the cervix, sort of up. It becomes more flexible. So we also see the mucus plug forms. There are changes also to the structures of the vagina. The vaginal mucosa becomes thicker. Mom also becomes more susceptible to yeast infections because the pH changes. And we also start to see some dramatic changes in the breasts. The breast size increases under the influence of estrogen, and mom usually gets some increased pigmentation around the areola. And they think that that is because infants don't typically see well when they're newborns, and that contrast sort of helps them find their way around. Okay, so those are some of the, the autocorrect there didn't really do that right. There we go. Okay. Those are some of the changes that are associated with the reproductive system. And we're going to, I'm guessing you guys have had enough time with this to take your notes. If not, you can back it up later. We're going to move on to the other body systems because everything, as I said, is sort of affected. One of the systems that is most profoundly affected by pregnancy is the cardiovascular system. And we see a decrease in the peripheral resistance. So typically you will see a decrease in blood pressure. And that becomes sort of important in understanding why preeclampsia and gestational hypertension sort of go against the natural order of things. It is not normal to increase significantly during pregnancy. One of the most dramatic changes that we see is an increase, let me get that on there, in blood volume. And I want you to think about this. It goes up to 45 to 50% by term. Okay? That is an awful lot of extra fluid. And it's normal. For most healthy pregnant women, they tolerate that. But you guys remember when we talked about fluid balance, Mrs. Roberts went over with you what happens when your fluid volume increases. It looks like your hematocrit and your hemoglobin go down. Red blood cells also increase. How does that do that? I hate autocorrect. But not as dramatically. So they go up by about 30%, while your blood volume is going up 45 to 50%. And so we get what's called the pseudoanemia, or the physiologic anemia. I'll use both of those terms. Physiologic anemia of pregnancy, also called pseudo anemia. And what this means is mom's H&H are going to drop. They're not supposed to really drop more than, say, 11 for your hemoglobin. You can get superimposed anemia along with this hemodilution because the baby needs a little bit more iron to grow. But be aware that your H&H will decrease to some extent. And this is sort of an important thing to note, and I'm just putting this out there, that if your mom starts to bleed, her vital signs will stay stable for a pretty good long time. If you think about it, say that you and I have 10 units of blood circulating in our bodies, and we lose 2. Well, we've lost 20% of our blood volume, and we're going to start to see changes. Well, mom could have up to 15 units of blood. She loses 2. It's a little less significant, so her pulse and her pressure will stay relatively stable. And this is important because, A, yes, it's an adaptation that helps mom not go into shock if she has some bleeding. But the thing about it that I really want to point out is that by the time you start seeing changes in the vital sign, mom's already lost a significant amount of hemoglobin. So if she's lost 1,500 milliliters of blood, which is a really pretty large amount, especially for a vaginal delivery, she might still have a fairly decent pressure. Don't let that fool you. You still have to act because by the time mom crashes, you're really behind the 8 ball. And it was one of the things that sort of came up with the postpartum hemorrhage project is when they go over charts of maternal deaths, and you will cover postpartum hemorrhage as a separate unit. I don't want to steal Dr. Bates's thunder, but over and over again, they would find this trend of not spotting the signs and not rescuing moms who were really in trouble because, well, the pressure was 90 over 50, and then it was 86 over 47, but she's been running that, and by the time she's 70 over 30, and maybe she started at 110 over 60, now we're really behind the 8 ball. And she's lost a significant amount of hemoglobin, and it's a lot harder to get them back if you don't act promptly. So those are some of the changes. We also see an increase in coagulability. Pregnancy is a hypercoagulable state. And you know that's going to lead me into my favorite topic at some point of DVT prevention, because I think that's important no matter which area of nursing you end up going into. We know that mom's white count goes up significantly. In fact, mom can have a white count around 14 and not really have anything wrong with her. It's just a response. You can go up to 16,000 millimeters cubed in the absence of infection. It's unusual to see it as high as 16, but you'll also see it increase after delivery. When you get your first CBC back, you are going to see numbers that are like 16, 17, and that's okay. That's mom's normal increased white count on top of the response to pain, stress, and inflammation. So that is all normal. Mom is going to get, in the second trimester and later, something called vena cava syndrome. And this is sort of important when she lays in the supine position. Okay, and I'm going to put that there. Well, you know what? I'm going to put that up here, and I'm going to give it a little star. I bet you forgot about my stars, but let me do one anyway. Okay, so vena cava syndrome occurs. Mom's growing uterus sort of lays on that vena cava when she's laying flat on her back, and it impairs the blood return to the heart. So you've got all this blood in your lower extremities trying to get back to the heart. So mom will start to feel dizzy, she'll feel sweaty, she'll feel shaky, she might feel nauseous, and the baby's heart rate can take a dip at the same time. And that's just from the weight of the uterus and the baby on that major blood vessel. So the intervention for that is that you're just going to like flip her onto her side and get her off. Even if you can't totally turn mom to her side, you're going to at least displace that uterus by tilting that hip. And one last cardiovascular adaptation of pregnancy that I'm going to discuss is the increased venous pressure. And this can lead to some of your common complaints of pregnancy, including swollen ankles, that dependent edema, and sometimes your varicosities, and even hemorrhoids to some extent. And you think about it, progesterone, which relaxes everything, it relaxes the uterus. We're going to see when we talk about the changes to the GI system, it relaxes the bowel. It also relaxes the, the musculature around the veins. And there is some compression of the iliac veins and the inferior vena cava that help sort of make everything pool lower down. So you'll see edema and varicosities and hemorrhoids and things like that from the increase in venous pressure. Okay, so the next system that we're going to cover is the respiratory system. And yeah, let me put that out there. Okay, respiratory system is also affected. Your oxygen consumption goes up by about 15 to 20%. And that kind of goes along with the basal metabolic rate that also goes up. You get an increase in tidal volume. Mom's respiratory rate goes up slightly, but not that much. Don't be fooled into thinking she's going to have some crazy abnormal respiratory rate, and it's okay. It's not. Typically, I see moms hovering around 18 to 20 respirs per minute. Other changes we see to the respiratory system are nasal stuffiness, and that is a direct effect of estrogen. Along with that, you might see nosebleeds. Be careful of that, though. If mom has high pressures and her nosebleeds are getting out of control, you might want to check her pressure and see if something's going on. But because of all the changes to the mucosa, it's not uncommon, especially in the first trimester and the second trimester, to have a lot of stuffiness. Now, as mom gets a little further along in pregnancy, you might get pressure on her diaphragm from the growing baby, and she might complain that she has a little shortness of breath. It's not truly shortness of breath. If you put her on a pulse ox, she'll read 96 to 100% on room air. She's not working to breathe. It just feels like it's more effort to get a good deep breath. So that kind of sums up most of the changes to the respiratory system during pregnancy. Next, we see some changes to the renal system, or the genito-urinary system even. We can put that in there. Okay, the first thing mom's going to complain of early in pregnancy is increased frequency. Now, this isn't the same as the frequency you get with a UTI. This is just a baby growing and pressing on your bladder as your uterus enlarges. Everything's prime real estate. In the second trimester, that kind of lifts a little bit because the uterus expands out of the pelvis. But then in the third trimester, we see it again because the baby just gets heavier and bigger and sits right on that bladder. So you'll see that. You can sometimes see a little urinary incontinence, especially stress incontinence. There is an increased risk of UTI. And that has to do with the changing pH of the urine and the sort of decreased tone and capacity. We have an increase in renal blood flow. And an increase in the GFR, which is the glomerular filtration rate. So there's a lot going on. In the third trimester, you can see decreased renal flow, which means mom might get some edema because the kidneys aren't excreting it quite as quickly. And I'll just put that there. A lot of this stuff we're going to cover again when we talk about the normal discomforts of pregnancy. You can get more excretion, and this is sort of an adaptation too, of glucose and protein. But I want to caution you with this. I mean, your book makes it almost sound like it's a normal thing. It really is not a normal finding to have glucose and protein in the urine. In fact, any proteinuria, any significant proteinuria needs to be investigated because that's a symptom of PIH. And once present, really the amount doesn't matter that much. There's no real significant association with outcomes. Glucose, again, it's really, you don't want to be spilling sugar into the urine. Usually the body won't start excreting excreting glucose in the urine until you hit over 200. So if you're seeing glucose, you're really looking at usually some kind of gestational or pregestational diabetes. Ketones are another thing you don't really want to find in the urine. But that sort of wraps up changes to the renal system. And when we talk about the renal system, I'm just going to throw this out there. There's like a lot of little loose facts that I'll throw at you, and hopefully when we get a little further along in the content, you can stick them to things and get a better holistic sense. UTIs are common during pregnancy, but you want to be very careful with UTIs during pregnancy because they can go into what's called pyelonephritis, which is a serious kidney infection. It's common, especially among younger women. Causes high fevers. They get very sick from it. You might be able to treat pyelonephritis as an outpatient for most non-pregnant patients, but most of these people need to be brought in and given IV antibiotics and then maintained later. Like I said, that's part of a different unit if we even go into pyelonephritis. Just so that you understand, though, if you're teaching pregnant women how to keep themselves healthy, one of the things that you want to talk to them about is knowing the signs and symptoms of a UTI and getting treatment. And you also want to teach them about hygiene so that they can prevent them in the first place. The most common organism that causes that is E. coli, and a lot of it can be prevented with proper hygiene. So anyway, Not that you need to study pyelonephritis for right now, but let's move on. Changes to the GI system. Okay, so increased levels of HCG. That's the pregnancy hormone. That's human chorionic gonadotropin. It's secreted by the chorion, which is the fetal part of the placenta. Peaks early in pregnancy and then sort of levels off. But this leads to the infamous morning sickness. Sorry. And that is one of the things that we call a presumptive sign of pregnancy, along with breast changes and fatigue and the lack of having a period. That's a presumptive change. And again, we're going to cover presumptive changes again. Don't feel like you have to write everything down all at once. But the increased levels of HCG lead to morning sickness. And that's normal. It's almost reassuring for some moms to know that the hormones are working, not that it makes you feel great. Increased progesterone. Think about what it does on the uterus. It has a quieting effect on the uterus. It stops it from contracting. Well, it also slows the contraction of the smooth muscle in the bowel, which we also call peristalsis. And that's where you get your gas and your constipation and that bloating. And it sometimes helps you decrease your appetite a little bit. If nothing else, I hope you all appreciate your mothers after this unit for everything that they went through for you. You get changes in taste and smell, and this is a really, I always knew that I was pregnant when things would smell weird to me, or I couldn't stand the smell of certain things. Sorry, I spelled that wrong. I was talking. So changes in taste and smell, and this will give you your food aversions and your cravings. It's just a chemical thing. You might have an increase in appetite or a decrease. I think the first trimester, it was always for me like, bleh, I don't want to touch that. I don't want to smell it. I don't want to be near it. And then paradoxically, people will say that they want weird things that they never want any other time. Those are all due to those changes in taste and smell, and that has to do with the increase in estrogen. You might also get cravings for things that aren't food, and that's something we call pica. I have seen women bring in boxes of Argo cornstarch, and then you have to sort of tell them, like, no, that's not a great idea. That displaces a lot of other foods in your diet, and it really doesn't offer you anything. Pica can also involve chewing ice, clay and dirt, which is kind of weird, but people do it, especially down in the South. And it's sort of a primitive thing. It's also associated with iron deficiency anemia. So if the pregnant patient that you have is complaining of pica, you might want to investigate their H&H and recommend an iron supplement. You also can get, because of the estrogen, some swelling in the gums, some gingivitis, those things, and extra salivation. And this is called pitilism. You don't have to write that down. It won't show up on any of my exams, but I have seen women, they get the nausea, they get the vomiting, and then on top of it, they get this increased salivation where they just kind of spit a lot, and it's a little bit gross. And like I said, I hope you all appreciate your mothers a whole lot more after learning about some of this stuff. Okay, so we'll move on from GI changes. There's some of the more significant ones. We have changes to the musculoskeletal region as well. And I know you all know that the most common one is your lumbar lordosis. As the uterus grows, it sort of puts your posture out of alignment. You get that exaggerated curve in your lower back. If you don't know that from physical assessment and from musculoskeletal, you need to, get your memory checked, because I think we got really carried away with it. You also have a loosening of the joints, particularly in your third trimester, the closer you get to delivery, and that is from the effects of a hormone called relaxin. Relaxin is really only meant to work on one joint in the symphysis pubis, to sort of open up your pelvis and let the baby out. But somehow it ends up working on all the joints, including the ones in your feet, which mean that your foot size goes up like maybe half a size every pregnancy. You get that waddling gait, and you get an instability, which makes people more prone to falls. And that's something you should probably note for another day. Moms can injure themselves. So when they're asking you about recommendations for exercise, the general guideline is anything you're used to, but nothing that's going to make you clumsier or put you at higher risk for falls. The abdominal muscles will stretch, obviously. And sometimes this leads to a diastasis that does or does not go away. Am I spelling that right? Diastasis, yes. Spell check. Diastasis recti. And this is a separation of the muscles of the abdominal wall. And I have actually sometimes done a postpartum check on women whose muscles have not rejoined, and you can sort of palpate some of the abdominal contents, intestines and whatnot, while you're doing your postpartum check. So that's something to be aware of. The next system we're going to talk about is the integumentary system. And this is where you see some of the really interesting changes. We talked about the increased pigmentation to the areola. You will also get, like the melanin goes nuts. You get when this app updated, they put in a new autocorrect feature, and I'm not particularly fond of it, particularly when you have to use a lot of medical words that are Latin origin. Linea nigra is a dark line. And if you hang on one second, I'm going to try and find a picture of it. There it is. It's this dark line right here. And that's caused by changes in the melanin. And it's what's really interesting is that you'll see sometimes baby girls are born, and because of the influence of mom's hormones, they'll have a little linea nigra. So that's a linea nigra. It goes away when you're not pregnant anymore. So let me just kind of, yep, I want to get rid of it. There we go. Okay. Another change that you might see in pregnancy is striae or stretch marks. Really not loving the autocorrect. Sorry. Between my typing and what explain everything decides is appropriate, you might get anything. Striae or stretch marks. You know that they start out. You know this from Jarvis, physical assessment course. They start out, they're reddish purplish. I'll see if I can find you a picture in a minute. I know you've seen them already. And they fade to a silvery white. And that's just because of the stretching to, all of the skin in the abdomen. You may also see them in the buttocks or thighs because moms put on weight in other areas too as fat stores for breastfeeding. So let me see if I can find a picture of the next thing we're going to talk about. Hold on one sec. Okay, and that is cloasma. You can also see it referred to as melasma. Oh my goodness, I don't even know that that's a word. Melasma, okay. And you can see this girl on the right side of the picture has normal pigmentation, but on the left, when she's pregnant, the increased estrogen and progesterone stimulate that melanin production. So that's cloasma. It's normal. It's not anything horrible, but people do sometimes get a little freaked out by it. So if the mom comes to you, you just tell her when you're not pregnant anymore and that estrogen and progesterone are gone, you'll lose that pigmentation. Other things you see in the skin are flushing, and that's just from increased blood flow. You have all that extra circulating volume, you have a little increase in temperature, and you get this vasomotor instability. It's a lot like menopause, where you just get that flushing. And you can get sometimes the increased estrogen will lead to, and I don't see this too commonly, angiomas. They do have, oh my goodness. They do happen. It's not as common as chloasma or flushing or stretch marks, certainly, but they can happen. Mom might have some redness of the palms. And last but not least, mom might have some skin breakouts. Just from the general upheaval of the hormones, increased androgens. So that is a wrap-up of all the things that happen to mom's skin as a result of being pregnant. So the next system we're going to discuss is the endocrine system, and that's where we see some of the major changes. We've already talked about some. We get a decrease in FSH. Obviously, we don't need any more follicles to be stimulated. There's no more ovum to be released for a while, so we don't need that. You get an increase in estrogen and an increase in progesterone. And these two hormones are responsible. Obviously, we've been talking about them a lot. Estrogen sort of builds everything, and progesterone keeps it from getting wiped away. Maintains a pregnancy. Progesterone maintains a pregnancy by relaxation of smooth muscles, whereas the estrogen sort of facilitates the growth in the vascular system and the breast development, and basically just helps the uterus grow. So if you think of it that way, it kind of makes sense. And when we talk about preterm labor and the one medication that is approved by the FDA to treat it, we're going to talk about progesterone's role again. We have an increase in prolactin, although truthfully that hormone is going to get increased more at about day 3 through 5 when the mature milk comes in. Increased oxytocin, more towards the end of pregnancy. And oxytocin, we don't want it to increase too much early in the pregnancy. But oxytocin is the hormone responsible for causing the uterus to contract for labor. Interesting thing is that you need both the production of oxytocin hormone and you need receptors on the cervix to cause labor. So in a perfect world, you would not have a lot of receptors on the uterus and not too much circulating oxytocin until you really need it closer to the onset of labor. There are also some hormones that we typically only see in pregnancy, and one of them is HCG, and that's human chorionic gonadotropin, and that maintains the corpus luteum, which is the body, the product of conception with the yolk sac, and it helps until the placenta is fully formed, and that takes a little while. We'll talk about placental development in a little bit. We also have HPL, or human placental lactogen, and this hormone is important to understand because secretion of this hormone increases insulin resistance. And the effects become really apparent in about the second trimester. So we'll talk about that a little bit more when we talk about pregestational and gestational diabetes. But HPL alters your metabolism and helps you get more circulating glucose to meet the needs of the fetus. In somebody who's got any kind of insulin resistance issue or underlying pancreatic issue, you will see problems with glucose metabolism. HPL also helps fetal growth. Insulin in the body for a fetus is sort of like a growth hormone, and we'll talk about that a little bit more. as we move into like more pregnancy risk categories. And the thyroid undergoes some changes too. It increases in size, and thyroid hormone production increases. So that's another big change. And you will have also, and put that over there, an increase in circulating cortisol. And now you can kind of see why mom gets so wacky during pregnancy. Every single hormonal system is just about affected. So we'll move on. Let me just kind of get rid of some of this stuff and make some room to the next system. And the next system is your nervous system. Oh, mom gets headaches. She might get fainting, which is also known as syncope. Typically, though, the nervous system doesn't undergo a whole lot of change. And most of this is just related to the increase in blood flow. When you have all this vasodilation and an increase in blood volume, you get more migraines. Interestingly enough, when we talk about hyperemesis, we're going to talk about the connection of migraine headaches to that. Okay, so that is how the body sort of adapts to pregnancy along all the major systems. Okay, so moving on to our next topic, and this won't really take too long, and we'll do some fun exercises in class maybe. How do we diagnose pregnancy? How do we know that pregnancy is occurring? Well, we have presumptive signs. So let's move this up here, and we'll make it all about the presumptive signs. And these are the things that make it seem like mom could be pregnant. But they aren't actually evidence of pregnancy. They could be explained by a lot of different things. And the first thing that mom will usually report is that she's not getting her period. She's missed at least one. Particularly if mom has been regular for most of her reproductive life, the absence of a period is a pretty good presumptive sign. And it's usually one indication for having a pregnancy test. Now you have nausea and vomiting. Mom will report at about, they say weeks 2 to 12. Some women won't have it right away, usually week 3, 4. This is due again to that HCG and the increased estrogen. Some women only get mild nausea. Some women vomit every day. Some women go into what's called hyperemesis. But nausea and vomiting are presumptive because we could be nauseous and we can throw up for many different reasons. Then you get your breast changes. Mom reports that her breasts are tender, that they're enlarged. She might get some tingling. And they look different. They're going to feel and look different. They get a little bit more glandular. You might see more vessels, like veins under the skin. The darkening of the areola are all breast changes. They can, however, be caused by other things, particularly the tenderness and the enlargement, and the tingling could be from premenstrual syndrome. So they are considered a presumptive sign. They're usually the first sign that most women report. Fatigue, and this is an ungodly fatigue. This is I could lay down in the middle of a crowded bus station and fall asleep at 2 o'clock in the afternoon. It is a really weird sleepiness that comes over most women, and it lasts for the whole first trimester. Usually is something that almost every woman reports. Fatigue should lift when a woman enters the second trimester. And if it doesn't, you have to kind of wonder what's going on. That's how they caught my diabetes with Melissa. I was in the second trimester, 16, 17, 18 weeks, and just not feeling any better, constantly tired. They ran a lot of tests, and that's what they found. But fatigue is a presumptive sign, especially if you have a cluster of these signs. They sort of paint a picture. And then you have urinary frequency. Again, it can be caused by other things, but if you have all of these symptoms at once, mom has a pretty good idea that she may be pregnant. And she's probably attributing all of that to this. Now, you have quickening. And this is kind of interesting. For those of you who have felt fetal movement before, it's kind of hard to mistake it for anything else. But there are some first-time moms who either don't know that they're having fetal movement because they don't expect it to feel that way. And there are moms who will say at like 12 weeks, I felt the baby move. And really what it is because their peristalsis is slowed down. They're feeling a lot more like that gas is a little bit more pronounced. So quickening can be explained by other things. Typically, though, once you get past those early movements, first-time moms will feel them at about 20 weeks. Let me make a note of that because that could show up somewhere. Multips will feel them at about 16 weeks. And that's because your abdominal wall is a little bit more relaxed and you kind of know what things feel like. In the beginning, fetal movement sort of feels like a fish swimming in a bowl and like tapping into the sides. Later, you start to feel elbows and knees, and you can't mistake it really for anything else. I was always sort of fascinated by those people who swore that they didn't know they were pregnant until they delivered a 38-week infant, because none of my kids ever let me sleep. They were crazy that way. There was a lot of movement going on, and it feels like really nothing else I've ever felt. It feels like being kicked in the stomach from the inside, which is what's happening. So those are the presumptive signs of pregnancy. Let me see if I can get them up there long enough for you to take a note, and then we're going to take them down. Okay. Probable signs of pregnancy. And these are really pretty reliable indicators. They could be explained by other things, but it's not real likely that they're caused by anything else. And for example, probable sign of pregnancy could be a positive pregnancy test. Pregnancy tests test for the presence of HCG in the urine. And some of them are really sensitive. They will test positive. Even the home tests will test positive for some women 5 days before the period is expected, the menstrual period is expected. To get a really accurate result on a pregnancy test, you should use the first morning's urine before you've had anything to drink. That's the most concentrated. But positive pregnancy test is considered probable because there are a very few number of things that can cause it to be a false positive. For example, early menopause and other hormonal problems, or if you've had a miscarriage, you might still have some circulating HCG while your body is adjusting. Okay. Other probable signs of pregnancy, uterine growth. And, you can palpate the uterus and abdominal growth. The only thing is that is not a positive sign because the uterus can grow because it has fibroids, or it can grow because of cancer. Hopefully those aren't the explanations for the uterus to grow, but that is a possible explanation. And then we have some of the signs that you will only see in the doctor's office. Chadwick's sign, or in the hospital. Chadwick's sign is like a bluish color of the vaginal mucosa and the cervix. You see it at about 6 to 8 weeks. I remember the first time I shadowed Dr. Brodkin in his office when I was a nursing student, and he let me watch a speculum exam. And it was not quite as blue as I expected. It was more of a purpley color. But it's like a purple dusky, it's just a lot of blood flow is going to that area, so you do get that bluish coloration. And then you have Goodell's sign. And Goodell's sign is just a general softening of the cervix and vagina. You do get some mucoid discharge, and you can usually see that or feel that at about 8 weeks. And Heger's sign is you can flex what they call the isthmus of the cervix. It's very flexible. You can flex that bottom portion of the uterine segment. Okay, your book also lists like cloasma and the linea nigra and the discoloration of the nipples and areola. So we'll put that there, skin changes. But they can also be caused by hormonal imbalances and ballottement. Which is something that an examiner can feel when they're doing a vaginal exam. They can tap the cervix, and it causes a rise in the amniotic fluid. Generally, you don't see it until 16 to 18 weeks, but at that point, usually pregnancy is well confirmed. I'm going to have to write a complaint to these people. I don't even know, ballot tempest, what that would be. But anyway, so those are some probable signs of pregnancy. And generally, you can assume that the woman is pregnant if she has most of these signs. So there. Now, positive signs of pregnancy. If we want to get, we're really not sure. There we go. You want to know what the positive signs of pregnancy are. These are things that you cannot explain any other way. So fetal heart tones. And particularly when you hear them by Doppler, you're going to maybe palpate mom's pulse and make sure she's not just tachycardic. But it's a very easy distinction. When you hear fetal heart tones, whether you hear them with a Doppler or a fetal monitor, I'm assuming a fetoscope, although I really have never used one, and I don't know anyone who has. Fetal heart tones there's a rhythm and a rate to them that sounds like shh, 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 shh. Whereas mom's heart rate will sound more like a normal heart rate. You can hear fetal heart tones with a Doppler, a handheld ultrasound Doppler, at about 10 to 12 weeks. I think your book says 8 to 12. If you're working in the emergency room, please do not call the labor and delivery nurse down to listen to an 8-week fetus with a Doppler, because all you're going to do is really freak out the mom if they don't hear it. A couple times I remember this situation, and they would swear to me, the mom is like second trimester, and you get down there and you say, well, when was your last period? And you calculate it out, and you find out that mom was really only maybe 8 or 9 weeks. And she's there because she's got a little spotting or she's worried. And now you have to explain to her, I might not hear anything, and it doesn't mean that anything's wrong with your baby. It just means that I'm looking for something about the size of a grain of rice buried deep in your pelvis. And you have to angle that Doppler just so, right above that pubic bone, and really dig to find it. And even then you might hear like just a trace for like 2 seconds, and then it's gone. Baby still has a lot of room to move, and it's a very small heart. It's not an easy thing to find. Plus, babies don't tend to like the Doppler. They don't like ultrasound. Apparently, the ultrasound causes waves in the amniotic fluid that sound almost like being at an airport, and they tend to like run away from it. So tell moms 10 to 12 weeks generally for the Doppler, although you can sometimes hear them at 8 or 9. It also depends on how big mom is. You can hear them with a fetoscope at about 20 weeks, maybe 16 to 20 weeks, but generally that. You can palpate fetal movement. And when you palpate fetal movement, it's pretty easy to tell that it can't be anything else. Sometimes just the coldness of your hands or the noise in the room will cause the baby to move. And you can feel it, given that mom's abdominal wall she's not morbidly obese. You can usually feel it at about 20 weeks gestation. And ultrasound. If you can visualize the fetus, it's there. And there is no other explanation for it. You can diagnose a pregnancy with vaginal ultrasound at about 4.5 to 5 weeks gestation. Early ultrasound is done really to date pregnancies and to confirm pregnancies, especially if there's a problem. And at any time that mom doesn't have regular cycles, or if there's any discrepancy between size and dates, they may do a dating ultrasound. The earlier in pregnancy that you do one, the more accurate it is. It kind of kills me when they'll do one and say, oh, this baby's 36 weeks. And then, they want to kind of argue that the baby doesn't need to go to NICU because it's 36 weeks by a late ultrasound. So Those are all some positive signs of pregnancy and ways to diagnose pregnancy. Fix that. And we're going to start talking about calculating the EDD, and this is kind of a fun game to do. You can actually get an app on your phone or on your iPad that will do the EDD for you. And I have wheels to give you guys from the March of Dimes, because they have such lovely products. But the estimated date of delivery, otherwise referred to as the EDD, can be calculated using Nagel's rule. And I'm going to have to refer to your book to spell it correctly, because it's not something... wait. There we go. That I spell out a whole lot. But Nagel's rule is... Let's get rid of this picture. I want some room to work there. And let's get rid of that. We don't need that. So the estimated date of delivery, we're going to use Nagel's rule. And Nagel's rule says, take the first day of the last menstrual period. LMP for short. Okay. Now you're going to subtract 3 months from that day. Then you're going to add 1 week to that day, that date. And then you're going to add 1 year, because we don't want to go back in time. I never even thought to add the year. I was always just looking for the day, and I would assume most people had enough common sense to know that they weren't going to give birth the year before they got pregnant, but you never know. In terms of test taking, we want to make sure that you have every advantage you need. So let's practice that. Let's say that mom's LMP was, let's go with St. Patrick's Day. Okay. Using Nagel's rule, you want to go back in time 3 months. So February, January, December. Now we're at December 17th. Okay. Now we want to add 1 week. So 7 days to December 17th gives us December 24th. Wow, Christmas Eve. Now, if her period was March 17th of 2016, obviously she's not going to give birth in 2015. She's going to give birth in 2016. So we're going to add a year to that, December 17th or December 24th. And she's going to give birth on December 24th of 2016. And let's fix this up here just so we're totally crystal clear. Now, this is sort of where things get interesting. I was at Bucks my very first year as a lab facilitator for Mrs. Mert, who teaches the part of the OB content. And she had to teach some people. I guess they had never heard the nursery rhyme. 30 days has September, April, June, and November. All the rest have 31, except for February, all alone. Well, if you haven't heard that nursery rhyme, I feel bad for you. But keep in mind that the number of days in a month is not random. It does not change from year to year. Some students apparently labored under that misconception and thought, well, how will you know how many days are in a month? Don't you have to check the calendar every single year? Well, no. Matter of fact, you don't, unless it happens to be a leap year. So when you are calculating the date of delivery, just so you know, she had a little trick with knuckles. I can show it to you in class, but it's almost embarrassing to think that people don't know how many days are in any given month. Anyway, we'll go over it again. 30 days has September, April, June, and November. Apologize that they're not in order. All the rest have 31. Okay, so that would be January. Remember, February is all alone. March, May, July, August, and October. Again, they're not in order. Well, those ones kind of are. The first ones weren't. The only way I remember these is the nursery rhyme, and just from having done them so many times. Anyway, February, we all know, has 28 days except in leap year, when it has 29. Now, not that it really matters. Most people don't give birth on their due dates. They give birth within 2 weeks either way, from 38 weeks to 42 weeks. And I'll give you a wheel, which is a much simpler way to do it. But you should know how to calculate Nagel's rule. In fact, I'm going to give you some exercises in class to do that. And yeah, let's kind of do one more, just because these do tend to show up on tests. Everybody loves to put questions on Nagel's rule because people like to know their due dates. Like I said, you'll use a wheel or you'll use an app. But if mom's last period began, let's see, I'm going to make it February 27th. Clarify 2016. That was a big stumbling block for some of the people at Bucks. I don't know why. Calculate the expected date of delivery. I'm not going to work it out for you. I'm just going to give you a few minutes, seconds really. Remember that February is a leap year in 2016, so that will make a difference. That's right. She'll give birth November 5th, 2016. All right. If you have any questions about that, see me in class. It's really not a tough concept. It's just something that tends to show up on exams of one kind or another. ATI, maybe mine, I don't know. I do like the wheel. I think it's better. The pregnancy wheel, hold on one second. I'm going to find a picture of it. Okay, there it is. Let me see if I can make it a little bit bigger. You can see that it not only calculates your due date, but it also tells you what week the patient is in. And it's a lot easier to calculate that. So if somebody comes to OB triage and they give you their last menstrual period, or even if they give you your due date, you can kind of play with this wheel and find out, is she 16 weeks? Is she 25 weeks? Is she 38 weeks? And that's sort of more helpful to you. And if you give these to pregnant moms, a lot of times the ones, maybe the one that the March of Dimes sent me that I can give to you, has little events of fetal development, which is always fun for the mom. Okay, and we're going to talk a little bit about some of the normal discomforts of pregnancy. And we've already touched on a lot of this as we went through the changes to the body system, but it's like the last thing that we're going to discuss for this part of the unit, and then we'll move on to prenatal assessment and then health promotion. But you're talking about the normal discomforts of pregnancy. They are grouped according to trimester. Some of them will sort of last or just intensify all through pregnancy. But first trimester, we already kind of talked about fatigue. And like I said, it's that ungodly, like, oh my God, I could lay down right here in the middle of everywhere and just go to sleep. And then you get breast changes. And I'm sorry if this seems a little bit repetitive, but sometimes it's nice to have the information presented more than once. Breast changes, like I said, there's a change in the color to the areola and the nipples. They enlarge. Sometimes those veins are a little distended and they're easily seen under the surface of the skin. They're tender, they're sore. They may even feel a little bit glandular and heavier. So there are breast changes. There is nausea and vomiting. And there are some things that we can do to ease that. Telling mom to eat small, frequent meals. Telling mom to take her prenatal vitamins in the evening instead of in the morning or whenever she's least sick. because the prenatal vitamins can make her really nauseous. You do get some constipation. Again, that's partly the progesterone and partly from the iron supplements that mom's taking. You get sometimes excessive salivation. You get nasal stuffiness. You get sensitivity to tastes and smells. So these are all things that sort of are normal discomforts of pregnancy that happen in the first trimester. And then in second trimester women usually feel pretty good. Their energy comes back. They're not nauseous anymore. They're starting to show, and they're a little bit proud of their bump. Their partner's usually adapting to it. Other people can feel the baby move. She can feel the baby move. So second trimester is generally a feeling good kind of time. Usually the pressure relieves off her bladder too. I didn't say urinary frequency with the last slide, but you can just jot a note under there so I don't have to redo that. So in the second trimester, the big thing that you're going to see is uterine enlargement. This is when mom usually has to wear her maternity clothes. You can see a little bit of that lumbar lordosis, although it's usually not too bad early on. She could have a little backache from that. Nasal stuffiness continues. So those are some things you see in the second trimester. This is also when you get your supine hypotension syndrome, usually after week 20. The fundus of the uterus, which is the top portion of the uterus, reaches the umbilicus or the belly button by about 20 weeks and grows about 1 centimeter a week after that. Okay, and so you have this growing uterus, the weight of the baby, the weight of the placenta, the weight of the amniotic fluid, all laying on the vena cava. This is also known, by the way, and I already said it once, vena cava syndrome. And what it is, you lay mom on her back, she feels nauseous, she feels lightheaded, she feels dizzy. If you are monitoring the baby, you will notice sometimes a dip in the heart rate, in which case you better turn mom pretty quick. The only thing you really have to do for this is make sure mom doesn't lay on her back, and if she is laying on her back, you kind of tilt her. Maybe you put a pillow under the left hip. We always like the left side. So that is your second trimester. Second trimester, like I said, most women feel pretty good. Now the third trimester is when most people start to feel uncomfortable. And at this point, they want to be delivered. And that is has been sort of a problem when you had these elective inductions at 37 weeks, sometimes a little sooner, just for to relieve the discomforts of pregnancy. So third trimester discomforts include a lot of the same first trimester discomforts, but now we have big, heavy babies, so we'll go with fatigue. Mom starts to get really tired again. Now she needs to nap. Of course, part of that is because baby's keeping her awake at night between having to empty her bladder and the frequent kicking. Some women will also have problem with carpal tunnel. I did. That was probably my biggest complaint towards the end, was the carpal tunnel syndrome. Your wrists start to hurt. You get tingling and numbness in your fingers, and that used to keep me awake. So you do get that. You can have that waddling gait and the looseness of the joints and the lumbar lordosis again. This is usually very much more pronounced at this stage of the game, and backache. especially when you have to stand. Sorry, let me move some stuff here. You might also get some dependent edema in the ankles. Now, when we talk about edema, you're going to hear reference to pitting edema when we talk about preeclampsia. The American Congress of Obstetrics and Gynecology, or ACOG, has taken edema off of the diagnostic criteria for PIH, but those of us who have assessed a lot of pregnant ladies know that when they're getting in trouble and they have preeclampsia, they get swollen. And not just swollen in the ankles. You can have some great big Fred Flintstone ankles. But the biggest biggest sort of soft sign of preeclampsia is when their fingers and their hands, their rings get tight, their faces get tight, their faces get very, very swollen. Those are sort of things that, again, they were taken off of the diagnostic criteria, but those of us who have worked with pregnant ladies and preeclampsia for a long time do notice that there is that puffy, sick look that people get. So those are some of the more common discomforts of pregnancy and things that we can do about them. Fatigue, we can always recommend rest periods, naps. Let people help you when they can. For the nausea and vomiting, like I said, the small meals throughout the day, dry crackers, toast, nothing fried, nothing greasy. Oh, you know what? I forgot to mention heartburn. Heartburn sometimes appears around the latter half of the second trimester and persists until it's really a problem in the third trimester. The things that we can do for that, don't eat anything fried. Same things that you would do for like hiatal hernia or GERD in a non-pregnant patient, with the exception that you're not going to recommend a lot of medications. Tums are generally okay. And we'll talk about medications that are safe during pregnancy. But you're definitely not going to recommend like your omeprazole and things like that. You want to keep upright after you eat. Avoid anything, no caffeine, nothing that's going to inflame the GI tract and esophagus. But heartburn sort of occurs because the sphincter, the LES, the lower esophageal sphincter, gets relaxed under the influence of progesterone, and also the growing fetus sort of displaces things. So you're just kind of a big setup for that. The old wives' tale was always that if you had a lot of heartburn, your kid's born with a lot of hair. I always think that's funny. I don't know how anyone came up with that connection, but there you go. So there are some things that we can do. For the edema of the ankles, we can have people sort of elevate their legs for an hour, kind of sit with their legs elevated, and that'll help the venous return. For carpal tunnel, we recommend lock-up splints for mom generally. Certainly not a time to be doing surgery. Usually she'll go back to normal after. She may or may not. For your urinary frequency, you want to make sure that mom is drinking enough liquids. I know, she's maybe annoyed that she has to go to the bathroom all the time, but you definitely want to encourage good hygiene and hydration. And so those are some of the things that we do for normal discomforts of pregnancy. Okay, now that we've covered all of the physiological aspects of pregnancy, or many of them, it's time to move on to the psychosocial and behavioral adaptations of pregnancy. And this is really where we see maternity care as a way of caring for the entire family. Although our emphasis is usually directed at the mother, this is a time where a family has to reorganize and readjust. Anyway, we do focus a lot on mom, and there are some maternal tasks that we worry about. The main thing that mom is worried about initially is providing a safe passage. And we see this in behaviors like seeking health care. This is one of those reasons why people who are late to care or people who don't seek prenatal care sort of send up some red flags for us as nurses. when they come in. It's like almost an automatic social service consult. We kind of wonder what was going on. Now, granted, there are many cultures that think of childbearing as a normal part of life, and they don't understand the importance of prenatal care. But part of providing a safe passage is giving yourself the advantage of the best medical care that you can access. Safe passage also includes things like smoking cessation and abstinence from alcohol or any kind of drugs, avoiding medications. This is a lot of moms will go on the internet and find out what's safe, what's not safe. So providing a safe passage is a major task. We have mentioned that pregnancy is a developmental crisis, and so this is part of that growth and development process for mom. The other thing that mom needs to do is to ensure that somebody else is going to love this kid, because parenting and raising a child is really not a one-person job. And this is why many adolescent pregnancies are at risk, because, in cultures where it's not acceptable for a woman to get pregnant before she's married or before she's of age to support herself, it may be difficult to get that social acceptance. Binding in. These are these attachment behaviors. And that's where you see mom singing to her baby, talking to her unborn baby, buying clothes for the baby, decorating the nursery. All of the things that show you that mom is sort of falling in love with this idealized baby that she hasn't met yet. So binding in is a really important phase. And there's a certain amount of sacrifice involved in parenting. In fact, a lot of it involves doing things for other people and not having time or energy to do them for yourself. So the mother has to be willing to sacrifice herself, some of herself, not all of it. Okay, so that's a really important part of this process, the maternal tasks of psychosocial adaptation. Now, it's normal. This is a really big job, all of this stuff. And all of it's in your book. I'm going to kind of X out of here to give myself a little more space. In the beginning, it is really, really, really normal for mom, even mom who has desperately desired a pregnancy, even if it's not her first baby, even if she planned it, even if she was an infertility patient. The first trimester, what we commonly see is ambivalence, a lot of it, and a little denial. Mom doesn't believe she's pregnant. She may feel nausea or tired, but she doesn't look different. Her clothes still fit. She can hide it from the world if she wants. There's a lot of ambivalence. And moms may feel horribly, horribly guilty for this. They may say, I really wanted this baby, but now I'm not sure if I'm ready to change everything in my life. And that's really normal in the first trimester. As we said, this is sort of a developmental crisis, and you kind of almost worry when people don't go through a little bit of cold feet. You just have to watch the reason for the ambivalence. Are they ambivalent because the relationship with the father of the baby is not good? Are they ambivalent because they aren't done with college or some other important task? And how ambivalent are they? Are they having really strong, intense feelings that are at conflict with one another? How hard is this woman fighting the adaptation? And if her ambivalence persists into the second and third trimesters, then we may have a little bit of a problem. And so these are ways to assess things at risk. However, if you had a mom who came to your office for the first visit and said, I really want my baby and I'm glad I'm pregnant, but I just feel weird about it and I'm not sure if I was really ready to do this. That's a normal finding. If they're in their third trimester and telling you, I think this was all a colossal mistake, then you have a mom who's at risk. As the pregnancy goes on, mom is going to identify with the motherhood role. And there are lots of ways, I'm sure you can think of some. These are the moms who are looking at all the different things on Babies R Us. They're looking for a pediatrician. They enjoy feeling the fetal heartbeat. They like seeing the baby on ultrasound. They enjoy feeling the baby kick most of the time. And moms, a lot of times, expectant moms will become closer to their own mothers at this time. And so this could be a good thing for for women who have had difficult relationships. A lot of times this is a time that people can reconcile those feelings. If she's very close to her mother, that'll be definitely a source of support to her. When a woman's mother is not available to her, for example, if there's been separation or there's been death, it is often helpful to her to find a substitute source of support from some other female relative, a mother-in-law, or a friend who's gone through the motherhood process. Now, also at this time, the relationship to the partner changes. Particularly if this is a first baby. In subsequent pregnancies, it may not be as big an issue. But generally, you'll find that a strong relationship will be stressed, but generally resolve all that developmental crisis, whereas a relationship that is already very stressed may become more conflicted. So you sort of have to be able to assess that dynamic. But those are some of the ways that mom adapts to a pregnancy. She also has to cope with fears about labor and birth. That's another big maternal task. Let me try and make some room here. And she has to prepare for the birth of her child. As well as learn the tasks of infant care and prepare a space for her baby. So those are a lot of pretty big jobs for a new mom. It all gets easier with each child, but with the second child, you start to worry, are you going to be able to juggle everybody's needs? And really, you know, that kind of goes on. Every child sort of causes the family to reorganize a little bit. Some things that might influence maternal adaptation. We talked about the first-time mom versus the second-time mom. I should define these terms for you. A nulla gravida, now I'm taking a little detour here, is somebody who has never been pregnant. A prima gravida is someone who is pregnant for the first time. A multigravida, I think you're noticing a pattern here, is somebody who's been pregnant more than once. Okay? Whoa, multigravies, that's a little bizarre. Hold on, let me... Okay, and then we go to parity. Gravida means you've been pregnant, and parity means that you have given birth. So we have the nullips. Nulliparous woman has never given birth. And you have your primips. A primiparous woman has given birth once. And you have your multips. A multiparous woman has given birth more than once. So, multiparity will influence how a woman adapts to pregnancy. If you have a little bit of experience, labor won't come as a shock to you. Now, of course, if you're doing a VBAC, oh, multiparty. This spell check is really, the autocorrect is really a problem. Okay. So, if you've had a child before, you're used to the experience of labor and delivery. Maybe you know a little bit of what to expect. Somebody who is VBACing might be almost like a prime in some respects, but they still have some idea of what to expect from the process usually. They know what it is to be up all night with a newborn. They know what it is to, have to provide for them, how to juggle your work and home life. So usually you're at a little bit of an advantage. As I said, each additional child does cause you to reorganize a little bit. And I know going from being being a mom of one child to being a mom of two, many mothers will tell you that there's a whole juggling act that happens. And one of your maternal tasks is going to be to prepare the siblings as part of that social network to welcome this new baby into the family. So things do change. It's never, there's never not an adaptation, but it is a lot easier if you've done it before. Other things that can influence. There we go. Our age, maternal age. Okay, so somebody who is a young adolescent has really big problems. And by young adolescent, I mean between the ages of, say, 11 and 15. This is a huge risk factor because they're still growing and developing themselves. And so the tasks of pregnancy are at total odds with the tasks of adolescence. And these patients will need a lot of social support, which they generally don't have. These are unplanned pregnancies, almost always. Sometimes there's an element of sexual abuse. So this is the patient that you are going to be the most concerned about in any scenario. We've had 13-year-olds give birth who were, if you went back by Nagel's rule, you could figure out that they were 12 when they were impregnated. And the teaching that you do to these folks has to be very, very different than even the later adolescent. And by that, I'm talking about the patient who is 16 to 19. They also have developmental tasks that aren't completed yet, that aren't related to pregnancy, and so they're at risk as well. But it does depend a lot on their social support network. If they have a mom who's involved, if the father of the baby can provide them with some support, if their, extended families, siblings can help them, they are at less risk. However, this is a definite risk factor because not only are they physically still growing, yet they are emotionally incomplete, and they have a lot of tasks to accomplish that are about becoming themselves. Motherhood, as you know, is about losing a little bit of yourself to be there for somebody else. So, this is a patient who's going to be sort of at risk. For your young adult population, your 20-something to, 30-something patient, this is generally the developmental phase that they're in, where we expect to see people mostly starting their families. And so the developmental crisis that it presents is sort of right on target with where their lives were. They're at intimacy versus isolation generally. And depending on where they are with their career goals and their life goals, pregnancy usually can fit in very nicely. And so they don't have too much trouble meeting the tasks. And then you have your woman over the age of like 35, where they have to sometimes, a lot of times this is a very planned pregnancy, this is something they want. However, this is a woman who's probably had a pretty good degree of independence, and so that part of parenting that involves sacrifice could be an issue if she's used to having a high-powered career or used to a lot of travel or things that are generally not as compatible to raising children. A woman over the age of 35 also is more prone to health risks, and so she might have a pregnancy that's a little bit more complicated, and she may have to adjust with coping with fear of complications. So those are some age-related factors that can influence adaptation, maternal adaptation pregnancy. We're still talking about mom. We have a lot to talk about with dad, too. Your book talks about lesbian mothers having special needs, and they do, but a lot of their special needs really deal with interfacing with the healthcare system and dealing with prejudice. in general, lesbian women who are having babies are no more likely to suffer a complicated, psychosocial adaptation. Really, the problem is more with the people around them and how those people react. So, that's another factor that can influence the psychosocial adaptation to pregnancy. Single parents. Now, this is where we kind of talked in that intro piece about there being different cultural norms for different people. Anymore, it's really common to see people walk in and they aren't married. Now, that doesn't necessarily mean that they're single. They could be cohabiting. They could be, they could have a very strong relationship. They just don't happen to be married. And there's a big difference between a single parent whose father of the baby is involved in their child's life and one that doesn't have social support. Single parents could also be well supported by their families of origin, if they have a network of extended family. So it's not always a predictor of a bad outcome. However, you need to make sure that there is some social network in place for this person and that social network is accepting of the child and the mother. So that's really where the risk comes in for single parents. Another thing that can sort of figure into that whole psychosocial adaptation is multiple gestation. Frequently you find this if you have a mom who's done infertility and she now has multiples, that ambivalence may be a little bit stronger because she's now facing the fact that she's going from desperately wanting a child and maybe never having the opportunity to do that into having 2 or 3 at once. And that's a big adjustment. Sometimes you need to counsel these families and make sure that they have what they need to successfully parent. There's something in your book about selective reduction. Now, generally speaking, I would say when I started my OB career, we did see a lot more triplets and sometimes higher order multiples like quads. But it's a lot less common now to see those higher order multiples. I mean, I think we have maybe a couple sets of triplets out there, but most of the time what you're seeing is twins. Selective reduction is really not an option when you're carrying only 2 babies. It's risky for both. And really even for triplets, a lot of times people will opt not to do that. I mean, I think we've all seen the reality shows, these people with like 8 babies or 6 babies at once, and that really is, that's almost malpractice, to be honest, because each additional fetus is putting all the other babies at risk and mom. So there is that in your book, but hopefully you won't really want to see too much of that going on. It is an adjustment to have a multiple gestation above and beyond what it would be for a singleton pregnancy, but most people resolve that crisis fairly well. Your book also talks about socioeconomic factors, and this is a big one. All mothers love their babies. All mothers want the best for their kids. And sometimes they just don't have the resources to provide them with all of the things that they need. And here in this area in Trenton, you can see a lot of that. People will leave the hospital, and especially at RMC, I mean, they'd be asking for diapers every 10 minutes, and you think, well, how many times did you change a diaper in the last, 2 hours? Because you've just asked me for your second pack of diapers. I never really questioned it. I just gave them out. There are reports of people out there who their babies get horrible rashes and UTIs from wearing the same diaper for 10 hours because they can't afford them. There's also barriers to care, to good quality pediatric care and obstetric care. Sometimes the struggles these people go through just to get juice and shoes for their kids, it's enough to, really want to pin a medal on some of them, but that can really influence your adaptation to pregnancy in terms of your psychology and behavior. So there's that. And then we have, talking more about women at risk. Your book mentions abused women. Pregnancy, because it's a developmental crisis, sometimes precipitates abuse. Fortunately, this is a time when most women enter the healthcare system, and we can ask them, when you do a prenatal assessment, which we'll talk about in the next video, you come right out and ask them. You wait until they're alone with you and you say, do you feel safe where you are? Has anyone ever made you feel unsafe? Has anyone hit, slapped, kicked, punched you? And when you address it head on, people may or may not answer honestly, but chances are they will give you some information. They may or may not act on what you tell them to do with it, but at least you've approached the subject and gotten them sort of thinking in the direction. You can help them make a safety plan, and we'll talk about that a little bit further. And then your book also mentions, and this was fairly common a few years ago when I worked at Lourdes. We had a lot of patients because one of our groups accepted TRICARE, which is the military insurance. But I remember there seemed to be like a big baby boom with the Fort Dix folks and the McGuire Air Force Base. You'd have people having their fourth and fifth baby while their husbands were deployed, and we had a whole program for Skyping them in, and it's a stressor. It's definitely a stressor, and a lot of these moms are sort of used to dealing for themselves. The thing that struck me was that a lot of them did have that social support built in. They had the other women on the base to sort of help them adapt. They weren't really alone, which was great, but it's still a stressor and can place a family at risk. So the dad has a big job to do to get ready for this baby as well. And dads respond in a number of ways. Oh, wait a minute, let me fix that a little bit. Some dads are excited and they embrace it and they get very into it. And they read all the books and they go through all of the classes and they go to every office visit with the mom. Others are sort of looking at it from the point of view of how they're going to provide financially for this child. And that can be a stressor for them. And a lot of this is cultural. Some cultures encourage participation and some sort of want the man out of it completely. It's always sort of interesting to see when we have families from different cultures like the Middle East, and dad might be praying or chanting in a corner while mom is screaming in the bed. And they don't really necessarily get directly involved. But usually in that case, mom has the women in her family to help support. There is a change in the relationship structure between the prospective parents, and sometimes this causes enough stress that you see domestic violence escalate or initiate. You might see some infidelity, and you really have to pay attention. Most people won't volunteer this information to you either on a visit or in the hospital unless you kind of need to assess the situation, get a feeling for what the relationship is. And again, that domestic violence issue really needs to be addressed head on in pregnancy. As I said, pregnancy is a time when women enter the healthcare system when they're not sick. So if you can get them involved now, your outcomes will be better. Okay, there are 3 phases that dad goes through on his journey to fatherhood. And the first one is called the announcement phase. Gotta forgive the background noise. They're having some fun outside. And the announcement phase can last a few hours or a few weeks, and this is when mom announces to dad and then the couple announces to the world that they are expecting a child. And there are a lot of different emotions that dads can feel at this time, and it's not uncommon, again, to feel ambivalence. That's the big word. Initially, he's going to accept the fact that his partner is pregnant, and then he has to think about what kind of a dad he wants to be, and he's going to try and embrace that role. Okay, the second phase is called the moratorium phase. And this phase is usually dad looks like he's not too involved. That may not really be the case, but generally things are he's trying to keep things as normal as possible. However, he is adapting There may be conflict between the woman who is, totally engrossed in her pregnancy and looking at baby clothes and buying maternity clothes and very absorbed in her changing body, and the man who just kind of wants things to be normal. There may be problems in the sexual relationship or just adjustments that need to be made. And the main task that Dad's going to complete during this time is to accept the changes in his partner's body, which at this point will become increasingly visible and become a bigger part of their lives. And the last phase of paternal adaptation to pregnancy is called the focusing phase. And during this phase, the men begin to assume the role of father. They help prepare for labor and birth with the woman. Sometimes they're putting together strollers or they're painting the nursery. They're anticipating fatherhood. Okay, and moms and dads aren't the only people expecting babies. We also have grandparents. And grandparent adaptation is usually not too complicated unless the mother's social situation is such that she's relying on grandparents for support and they're not capable or willing to provide it. But generally grandparent adaptation, even though it does mark like some profound changes, it's generally not a complicated process. Sibling adaptation, on the other hand, depending on the age and developmental needs of the child, can be a little bit more intense and require a little more preparation. Obviously, the younger the child is, the more difficult the adjustment. When you have children under the age of 2, they usually don't understand pregnancy and they will not understand the needs of the new baby. They probably will understand that it is a baby. I've seen lots of toddlers will point to the baby, 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 baby. But, as far as them understanding the concept of sharing mommy, those things can be a little bit difficult. And also, you have to make sure that you don't neglect the newborn safety or the toddler safety when you have a child under 2, because one of them will be mobile and one of them won't. And sometimes a very well-meaning sibling can cause harm to a newborn. So, preparation for those children, for children under the age of 2, there's really not a lot you can do to cognitively prepare them. You just have to be prepared to give both children a lot of attention, and to that end, grandparents can be very important. Children ages 2 to 4 typically can be able to understand the changes in mom's body and the arrival of a sibling. And, you can read them little stories and sort of get them involved that way, help them pick out some of the baby's clothes or the nursery. I've had some parents who will let the sibling choose the name, which is risky. But children ages 2 to 4 might also have a lot of their own developmental crises going on. For example, toilet training. Some children regress with the birth of a sibling. If you're going to change their sleeping arrangements, it's suggested you do that before the baby comes. Any kind of move to the house, try to dissociate those events so that the child doesn't start to associate their sibling with something traumatic to them. From 4 to 6, these kids really get involved. They like to come to visits. They like to feel mommy's belly when the baby's kicking. They will draw pictures for their sibling. If you're looking at like 3 or more children, the oldest one generally has already adopted that role with other siblings. And that's really kind of a nice age to introduce a sibling. The only thing that sometimes they have a difficulty understanding is that the baby's so little that it's not going to be able to play with them. They may want to play with the baby's toys. You might see a little regression, but typically not as much as what you see with the children ages 2 to 4. School-age children are usually very excited about pregnancy and childbearing. And adolescents might be a little just grossed out by the idea, or they may be really interested in it. They might be embarrassed. They might be completely indifferent. So there are all different ways that siblings adapt to pregnancy. And if the family is not under too much stress, generally the siblings will adapt well. So when do we know that it's getting complicated? Well, You won't always know, but there are some bigger red flags. Like I said, somebody who doesn't seek care or who seeks care very late, somebody who has missed a number of appointments, so late to care or no prenatal care. Missed appointments. Most moms, now granted, if you are somebody who's got a lifestyle where it might be hard to find transportation to the doctor, or maybe you have to work or you have very little support, you may miss appointments for things that are kind of beyond your control. It's still a red flag. A prenatal appointment should be something that's really, really important that the mom looks forward to. So when she's missed 1 or 2 or 3 appointments, sometimes we have people who miss 4 or more during a pregnancy, that sends up a lot of red flags. Most moms don't want to miss these appointments. They want to hear the baby's heart rate. They want to know everything's normal. So if they're not coming for their appointments, you want to find out what's going on. Any symptoms of depression, like flat affect, poor grooming, if they're still smoking after they've been told not to, or use of alcohol or substances. These are also big red flags that tip you off that there is something going on. You can have prenatal mood disorders, moms who suffer from depression, whether it's just a prenatal depression or whether they have ongoing issues with chronic major depressive disorder. Some moms have bipolar, so you want to assess for any history of mental health issues. And generally, you're gonna assess this at every visit. And you're going to ask her, so is everyone excited about the baby? How is dad doing with the pregnancy? You really have to assess it. And a lot of times, if mom is really struggling with something, she will open up and tell you if she has that basic trust that you're not going to judge. If, for example, father of the baby is incarcerated, if she feels that she has a trusting relationship with you and she can communicate that, she will. It doesn't mean that you need to, that you're not going to act on it, but just do this in a non-judgmental way. And if we suspect, especially in the hospital, in your OB area, or even prenatally, you can always refer to a professional. We refer usually in hospital to our social worker, Nina. And every hospital should have a good social services department. If you were working in a clinic, you might also work with a social worker. But if you were in a private OB office, you might talk to your provider and see who they want to refer, whether it's going to be like a psychiatrist or a psychologist or some other mental health professional. So that really completes our psychosocial and behavioral adaptations of pregnancy, as well as we did our physiological for part 2 of this unit. And our next unit will cover antenatal testing and assessment, and after that we'll talk about some health promotion.